Hey class, it's Kelly, Miss Camp, and due to the possibility of inclement weather, I'm putting my lecture on video. So hopefully you've done your reading this week. I heard you all did pretty well on the test, so that's awesome. Congratulations. I love skin. This is one of my favorite topics. I did this for about 4 years. I'm going to go through this pretty quick though, because I don't want you to fall asleep. But I do want you to watch this, and we're also going to have an assignment for participation points. So you'll get up to 5 points for watching this and for doing the assignment. So let's pretend we're in class together. This is chapter 24 in my book, Iggy. And so we're talking about hair, skin, and nails. Anatomy and physiology. Skin has got the subcutaneous fat, the dermis, and the epidermis. You've got your hair and your nails, and of course always have the glands. The glands are part of our sebaceous system of our skin and in our hair as well. The top of the nail is where also the nail is formed, and you have keratin there that helps form the nail. And as you probably know, if you harm your nail bad enough where your nail falls off, it will regrow more than likely. So here's a good picture of the anatomy of the skin. What's really important to remember is your epidermis, and then the next is the dermis, and your subcutaneous fat. And within the subcutaneous fat is where you find your blood vessels and your muscle, and down here is where you have your glands and hair follicles. Anatomy of the nail, again, is the proximal fold, your cuticle, and your nail bed, and the nail plate. Turn my phone off. And what's really important to know too, students, is assessment. I'm really big about assessment. You guys know that. And what's really important is to know the changes with age. As we age, our skin becomes thin, fragile. We don't heal as well. We bruise easily. Not as much fat there. And then due to accumulation of sun, being old and being alive as long as you have, you get hyperplasia or changes in the skin color. And the hyperplasia is what sets you up for precancers and cancerous lesions. I'd like to say we could all live in a cave, but we can't. So the more years you have on you, the more risk you're going to have for getting discoloration and hyperplasia of the skin. You'll also get change in pigmentation, and a decrease in vitamin D happens with older folks. And some people say, well, I'm out in the sun as much as a young person, but they still have a decrease in vitamin D, and it has to be related to hormones and other issues. So when you're getting an assessment, you always want to get the demographic data, socioeconomic. If you have a lady that works in a nursery, she's going to be getting more sun than someone that works in the office all the time. Drug use is important. You want to know if you have comorbidities like diabetes, things that impair skin healing. You're going to want to know a family history. People that have melanoma, family members have a four-time risk for development of melanoma. It's hereditary. So you want to know family history and genetic. And believe it or not, nutritional history. I always told you guys it's really important. If they're nutritionally deprived, they're going to be more at risk. Other things, current health problems, if they're bedridden, if things of that nature, allergies, of course, are very important as well. So when you inspect the skin, you want to look at the color, the moisture, the turgor, if there's any edema or lesions. And without going into great detail, you do have primary and secondary lesions. And what that basically means is a primary lesion, it would be like a mole or a changing mole, and a secondary lesion would be if you have cancer, lung cancer, and you develop a squamous cell, it's from that disease process. So when you're looking at these lesions, you want to do the A, B, C, D, E's of the lesion, okay? A being asymmetry of the shape. So if it's symmetrical, if it's perfectly round, that's good. If that mole's perfectly round. If it's irregular, then you want to note that because well, let's just do melanoma, okay? Because it's an easy one. Melanoma lesions are usually not symmetrical; they're asymmetrical. And then you want to check the border. Again, irregularity is not normal. If you have a perfectly round mole, it's been there for years, great. But if you have a new mole that is not perfectly normal borders, maybe it has scallop borders, that's not normal. Color is a big deal. Perfectly little brown mole is more normal than a blue or purple mole. And then the diameter, if it's greater than 6 millimeters, which is like the end of a pencil eraser, if it's bigger than that, then you might want to be worried about that. The last is if it's evolving or changing. So if you have a mole that you're worried about on your hand, you're a grown adult, but it keeps getting bigger. And last year it was much smaller, and this year it's twice in size. That's evolving. And one thing you have to remember about kids is as they grow, moles will grow. So this is a growing mole despite growth. Now, like I always say with assessment, you're going to have to look at these folks. You're going to have to inspect. You're going to have to palpate. If you're checking turgor, by gosh, you got to put your hands on them. The turgor can be checked on the chest. If it's a younger person, you can check on their arm. So turgor, if you're not going to really be osculating anything at this point, but you've got to get in there and really look at them. Look at their back, their neck, their buttocks. Overgrowth of hair, or people that have too much hair, is called hirsutism. You can have age-related. This is called just a senile lesion. It means it's not anything to worry about. This might even be an angioma. Those are normal with age and never going to hurt anything. And really discoloration, like I have some of my hands, is pretty much with age and sun exposure. I'm not sure what this is a picture of. I don't have my book. And then it just shows you some pictures of some more aging. She's got some discoloration, she's got some wrinkling here, discoloration on her hands. Older people have a lot of precancers, and those are like little rough spots you can feel. They might be stingy in nature, and those are the ones we treat with liquid nitrogen because they have about a 10 to 20% chance of becoming a skin cancer, so we treat them all. TKI is really not normal. These are like little blood blisters you see a lot of the times on legs. If you've ever seen on a child's abdomen, that could be a sign of meningitis, especially if they're febrile. But some people do get petechiae on their legs. It's not really common though. So if you see petechiae, there's usually a reason for that. There is a thing called a Schomburg's purpura, and people that wear too tight of socks can get that cayenne pepper looking petechiae, and that's pretty typical, so that's not a concerning petechiae. This is just talking about when you're doing assessment, you want to make sure there's no tears, that they're clean, that they don't have any, if they have tattoos and piercings, you need to note that on your assessment. It's a finding, right? Again, palpation, you want to confirm the size and consistency of the lesions. Is it macular? Macular means it's flat. Papular means it's raised. If you touch it, you can feel a bump. Moisture and the turgor. How elastic is the skin? And remember, in older people, their turgor is not going to be that great. Okay, so then it goes to hair assessment. And like I said, I kind of said overgrowth or hirsutism. Excessive, not only... this means like in a woman if they had a mustache, or if they're excessively having to shave their chin or something like that. And this is a hormonal imbalance. You're going to inspect though the scalp. Is it clean? Do you see nits? Do you see lice? Do you see dandruff? Dandruff's very common. It's a form of seborrheic dermatitis. Things of that nature. Are they losing their hair? Do they have patches of alopecia, which is baldness? Here's a picture of hirsutism. That goes kind of along with what's that disorder? Polycystic ovarian disease. Nail assessment. So you're going to be looking at their nails, right? I know everybody knows clubbing. Clubbing's related to smoking. You're going to be looking at dystrophy. What's their nails look like? Because we all know it should be just a nice, even nail. But does it look funny? Is it a different color, a different shape? Is there pitting? Is it paronychia? Okay, paronychia is an acute or chronic infection. Acute's going to be around the nail bed. It's going to be red. It's going to hurt. And sometimes you have to do an incision and drainage to make that better with some antibiotics or maybe some soaks. If it's chronic, those are people like us, nurses and other people that use their hands all the time, and they get chronic infections, and it's very painful. Okay, there's your nail. This would be abnormal if it was new, right? And if they hit it with a hammer, that'd be normal. But if they came to you and said, I've got this spot on my nail, that's a discoloration, and that's concerning. This would be a person, if it was new, I would take the nail off and do a biopsy underneath the nail to make sure it's not a melanoma. Okay, and this is talking about that paronychia right here. It's an infection of the nail bed. I always tell people, don't push your cuticles back. If you go and get manicures, it's fine, but don't let them push the cuticles back. And if you get a hangnail, be careful, because that can really become a problem. So this is important if you're looking at someone with darker skin. You want to make sure, if they've got paler, that usually is like a whiteness. Sometimes you can get patches of paler. Have you ever heard the term ashy? So a dark skinned person may appear ashy if they have dry skin or if they have a fungal infection, things of that nature. Okay, so after you've done your really good assessment, and this is going to be part of your assignment, I'm going to want you to do a really, really good assessment. Use your child, use your mom, use your dad, use your wife, your husband, I don't know, neighbor, whoever. And I put an 8-minute assessment on this week. Watch that and see how she does an 8-minute assessment on the skin. And then I want you to actually do an assessment on somebody. And we'll talk more about it, but what you're going to do with that assessment is you're going to apply it to what we're talking about right now, and then we're going to have you put it in a note, and I'll tell you what I want you to put in the note. So after you get your assessment done, you have a problem. We'll go back to melanoma, and I have a patient who has a blue, irregular, evolving 8-millimeter mole, okay? I'm like, whoa. And I've done her assessment. I've wrote this all out. Now I need to come up with, and my diagnosis is going to be a changing lesion, rule out melanoma. So what diagnostic tools am I going to apply to her to further evaluate her? Diagnostic assessment. So you can do lab tests if you think it's an infection, fungus. You can do a culture, and that's just what it is. You take a swab and you culture it. Typically, if it's a rash or a mole, we're going to biopsy those. And if it's a rash, you usually always want to do a punch biopsy. And so a punch biopsy is where you take a special tool, and they have a 1 millimeter that goes all the way to 10 millimeters. Okay, 1 millimeter is tiny, like the end of a pin. 10 millimeters is going to be about the size of maybe a dime. And this punch tool goes down to the skin. After you prep the skin, of course, you get a consent. You prep the skin, and you numb up the skin, and you're going to take this punch tool, just like I said, it goes down so far, because you're wanting to get about this much tissue to send and have them diagnostically test it to see what kind of rash it is. Is it bacterial? Is it fungal? Is it eczema? Is it allergic? Maybe just a contact dermatitis. Is it much worse? Could it be autoimmune, discoid lupus? A shave biopsy is if you have a mole that's sitting on top of the skin, a papule. You can get a consent, prep the skin, numb the skin, and you can shave that mole off and send that to a pathologist. And what's nice about that is if it's an unwanted mole, then it's just shaved off there perfectly, and usually it's a done deal. Excisional is going to be more for your melanomas. And if someone really suspects a melanoma, you are going to have to do a really deep, either a deep shave biopsy. Sometimes we just go ahead and do a punch and have to stitch it. And then if it comes back as melanoma, they'll come back and we'll have to cut it out with certain borders, and then sew it up, and then test that tissue to make sure that we have gotten it all. And if it's a deep mole, sometimes we have to do other tests like lymph node involvement, things like that. The Woods Light is kind of old. We don't really use that very much, but it's to rule out fungal, because when you use the Wood Light or the black light, it really helps to determine if it's fungal. Don't really use that much anymore, but it's Woods Light, just no fungus. And also you can do a scrape and look under the microscope with what they call a KOH slide as well to rule out fungus on that. There's a picture of the Woods Light, our lamp. Okay, so here's the audience questions, and you guys just look through this. I will go through them because I don't think you have access to them. So nurses watch the surgeon inject a local anesthesia and then use a small circular instrument to cut and remove a small plug of tissue. This is reflective of what? Okay, and it should be a punch biopsy. Okay. And here's the rationale. Okay. If it's a small punch, you do not have to stitch it. If you're going 6 to 10, sometimes you just have to put a single stitch in there. This kind of depends. A sweat and water evaporation can cause the body to lose how much fluid in a single day? It's an interesting question. It's kind of shocking. But it's the bigger one. It's D. Can you believe that? So you can lose a lot of fluid from sweating. So if you got a person that's working outdoors, it's good to note that. Patient asked the nurse to explain more about dandruff. Select all that apply. It is a cosmetic problem. People don't like it. It is not a symptom of dry scalp. That's something totally different. Dry scalp's just kind of itchy usually with no flaking. C is right. If untreated, it can lead to hair loss. D is right. It can be oily and contribute to dandruff. And then E, it can be patchy. Some people get seborrheic dermatitis or dandruff confused with psoriasis. And I have, in fact, got confused with psoriasis. Usually happens in the winter months. People under a great deal of stress tend to have it more. And with it, sometimes you can get the seborrheic dermatitis on the cracks of the nose here. You can get it in the ears. So you can see it in other places as well. Okay, so that is all of that video. And I'm going to go ahead and proceed on. I'm sorry, you kind of get this in the background. Next we're going to talk about problems with the skin. Don't forget that little assessment piece. Look at that. I want you to take a family member. I want you to assess them. Hey, I want you to sit down and ask them all the questions. You're going to have tons of time tomorrow if we don't have class. So you're going to be, again, I'm going to use my husband. I'm doing an assessment on him. He's a doctor. He's gotten minimal sun exposure. He's had a basal cell in his neck history. And he wears sun protection. He doesn't moisturize. He has no allergies. And in an assessment, you know, I found a mole. And I put my ABCDEs of this mole. And I'm going to do a punch biopsy. And We're going to talk about how I want y'all to implement that into your assignment. Okay, so this is patients with skin problems. It's common in older adults, pretty much, you know, what happens to older adults is their integrity of their skin changes, and they have comorbid states like diabetes, and they have more problems with skin problems. On the other hand, a lot of children have problems too. Children have new skin, so they're more prone to it, and then older people have older skin. And I love the old saying, I'll say, you know, you have eczema, it's probably related to your laundry detergent, and they'll say, I've been using Tide for 50 years. But they're older now, their hormones have changed, they have diabetes, things of that nature, and now the Tide has caused a skin reaction. So that's really a big deal, unfortunately, for older clients. So common, xerosis is just dry skin, very common. Today's society, with all the Bath and Body Works, with the smelly detergents and all the fabric softeners, those really dry the skin out. And the best thing you can do for dry skin is encourage folks to use a fragrance-free soap, fragrance-free laundry detergent, moisturize, and increase their fluids. Now, I will say, Chapter 25, without getting into great detail, has a lot of tables, and I'll try to point these tables out. You really need to look at these tables. They're going to help you zero in on assessing problems and educating folks, health promotion of skin problems. So again, dry skin, fragrance-free, watch the hot water, increase fluids, moisturize. We always tell folks mineral and Vaseline. Pruritus, itching. Itching can come from lots of things. Dry skin, eczema. It can come from a nerve disorder. Because just like pain, itching is on the same lines of pain. So the same neurotransmitter that causes pain causes itching. And so you have to remember that. Histamine release. Oh no, sorry about that. Okay. Histamine release. So that's if you get a laundry detergent that your skin does not like. It's going to fight it off. It's the fight or flight, and it's going to produce histamine, and then you're going to get an itchy rash from it. So that's the other thing. So most of these people with these conditions, what do you think you're going to be doing as a nurse? You're going to promote a healing and decrease discomfort, increase comfort, and then you're going to educate them so it never happens again. Sunburn's a big one in this area. They'll come in with this big, terrible sunburn. There's not much you can do to help them feel better, but you can educate them on how to prevent it with sunblocks and umbrellas and not going out between 10 and 2. Urticaria are hives, and this again is a histamine release. And it can be short-term, it can be long-term. People can get hives from heat, from stress. It's just a body's response to something. Sometimes we do all kinds of testing. We can't find out what exactly it is they're allergic to. Let's see, what else do I want to say? Sometimes you want to find out what the underlying cause is, okay? To the itching or the dry skin. Because sometimes it can just be as simple as eczema, which is an itchy rash from dry skin, or it can be a secondary problem from a medication. They can have a drug rash. And there is a thing called the scratch-itch cycle, when it feels so good and they scratch it. So you really want to, health promotion-wise, you really want to make sure these people keep their nails trimmed, that they take an antihistamine if indicated, and they use the cool air humidifiers. That helps keep their skin moist too. And sometimes just a break in the integrity of the skin can cause us all to spiral. So like bricks and mortar, think about your skin like bricks and mortar. When it's like this, we're doing great, but in the wintertime when it gets dry and it cracks, things can get in and out of these bricks and mortar and cause an itchy rash. So that same Tide used for 20 years can cause this itchy rash. So the winter, of course, is when things like this are the worst, okay? Insect bites, too, can also cause this type of situation. So it goes right into skin trauma. Basically what they're talking about is going to be inflammation, it's going to be a cut, an ulcer, and what's going to happen is you're going to have impaired tissue integrity and the possibility of infection, right? So the plan as a nurse in this situation is going to be promote normal wound healing and prevent further ulcerations, and maybe know what causes impaired healing so that you can mentally, if you have a patient, help to promote and reduce a wound. And you need to know the early signs, okay? And then this is the phases of wound healing. So make sure that you look in the book at that, of the phases of wound healing. Process of wound healing is first intention. It's where the edges are brought together and it lined up. This would be like if you had an appendectomy and now they're going to put the scar together and they're going to put sutures in there or staples. That's pretty common. Second intention is more like a deep ulcer where they're going to require gradual filling or second intention type closure. And then third intention is a delayed, like you have an infection. Example I give is like a dog bite. You don't ever want to suture a dog bite. You want it to heal from a third intention. And then it goes on to talk about thickness wounds. Make sure you look at your chapter about this. It's kind of common sense, but you've got your partial thickness, which can be superficial, involving the epidermis and the upper dermal area. And then you've got your full thickness wounds that are lower and deeper, the lower epidermis, and includes the subcutaneous tissue. And obviously the deeper ones are going to be a lot harder, right, to take care of and to improve. This is a picture of it. Okay, so it brings us to pressure ulcers. Pressure ulcers, you're going to see a lot of these in your nursing career, especially in the older people. Why? Because they're skinny and they're bony and may not move around much. They might be in a wheelchair or confined to a bed. So what you really need to know is there's decreased blood flow. I mean, because you're going to have compression on that tissue, right? So anytime you compress something, you're not getting adequate blood flow. And when that happens, you develop, the skin dies and develop ulcers. So you need to recognize the early signs of this. Mechanical can also cause, we know that, ulcers, right? Pressure, friction, or shear. So a way to prevent it is going to be to know who the high-risk patients are. And there is a table in your book that talks about high-risk patients. So make sure you look over that. There is a risk scale and a nutrition assessment, because if they're nutritionally deprived, then they're not going to be at normal risk, be at high risk. Implement aggressive intervention with the use of pressure relief devices. So you're going to want the beds, the air mattresses, and then you can do pressure mapping, which is computerized and helps tool areas that need this. I want to back up to early signs, table 25-2, blanching. Everybody know what blanching is? You push on your skin and it's white, that's blanching. Redness, you want to mark these areas and observe them. Get the pressure off by either using some means of a cushion or turning them. Involve the entire team, including the unlicensed personnel. Early detection, documenting and discussing, and maybe even implementing, like we talked about, an air mattress or a pressure mapping tool, because the earlier you can identify this, the better. When you're doing your assessment, let's go back to assessment, you're going to want to inspect the back, the buttocks, the back of the head, any bony prominences like the sacrum, even elbows. And if it's looking a little blanched or red, you may want to put a pillow there or some form of cushion. So key features and pressure ulcers in the stages is chart 25-3. So you need to make sure you look at that because it talks about the location, the size, the color, the blanching, necrotic tissue and what it looks like. So you need to really focus in on that. Contributing factors, like I talked about, it's going to be prolonged bed rest. So everybody in the hospital is going to be in this category. Immobility, incontinence. Why do you think incontinence? Because a wet area is going to include more breakdown quicker than a dry area. Diabetes, they have poor wound healing, so they're going to be more apt to this. Inadequate nutrition and hydration, and then peripheral vascular disease. So if they have a known history of ephemeral stent or some kind of arterial stenosis in the legs, then they're going to be more prone to that as well. So pressure relieving techniques, again, is going to be a capillary closing pressure, like a bed, a donut pillow, repositioning, things of that nature. And there's a section in your book that talks about planning to decrease the wound sign and to decrease new ulcers from forming. And there's a part in your book that talks about intervention, nursing, non-surgical and surgical intervention of wounds. Okay, so a stage 1 pressure ulcer. The skin is intact. The area is usually over bony prominence, does not blanch with pressure, and observe pressure-related alterations of intact skin. So this is stage 1. I don't know if my head's in the way or not here. Let's see here. Stage 1's right here. Okay, so stage 2, skin is not intact, okay? Partial thickness, loss of epidermis and dermis. You see an ulcer, it's superficial, may appear like a blister or a shallow crater, and no bruising. And you need to know this because you will get some test questions about staging of ulcers for sure. 3 is a full thickness skin loss. You see some subcutaneous tissue, you see some fascia. May see necrosis, may see bone or tendon. Actually, you shouldn't see bone or tendon at this stage. Bone and tendon is not exposed at this point. And you may have undermining or tunneling. Undermining or tunneling is where, if you have a gloved hand, if you can go under and feel some tunneling in there within the wound. And, you know, these are the ones that have to be debrided and sometimes have a drain put in. Okay, so this is the full thickness. You can see muscle, tendon. You may have undermining, tunneling, and you may have eschar present. It's really, really bad also. So know the stages of ulcers, okay? It's really important. That's going to also help you formulate your care. Again, we're always back to assessment. You're going to want to know the location, the size, the color, how much tissue is involved. You want to know the stage, right? You're going to want to know the margins. Is there any drainage? It's exudate. What does the rest of the tissue look like? Is there any foreign bodies involved? So you're going to really want to chart all that. There's a really good concept map in the book that you need to look at on on my page 445. And this concept map talks about a pressure ulcer. Okay? I don't know if y'all see that or not. Can't tell what you can see or not. We'll click right here. Maybe you can see it. Looks like that. It's in your book. Okay, that is a great thing to look at because that's going to give you an example of that patient, what he had going on, and what they did to assess and treat him. Infection, that's always going to be an issue if you have a wound like that, right? So that's where the wound dressings will come in, maybe topical antibiotic. You might need a wound care specialist. We might need hyperbaric chamber treatment because we really want to reduce the infection and treat the infection, right? So non-surgical, again, is going to be dressings, physical therapy. They can do whirlpool therapy. sometimes bleach baths. They could do a TENS unit or electrical stimulation, things of that nature. There's a hyperbaric. They had this at the Ozark Surgical Group, so we have that here. This talks about surgical intervention, debridement, and skin grafting. So they could take a flap of the skin, rotate it, and cover. The blood vessels are still intact, and the result is that it's closed with the skin graft, and it reduces the risk of infection. Okay, this has been going on now about 35 minutes, so I'm going to try to finish up. And we're going to talk about a few common problems like bacterial infections and things of that nature. So this is a furbuncle. It's a singular solid infection. And we would usually do an incision and drainage and the antibiotic therapy for this. This is an infection, usually staph-oriented. This is a folliculitis, and sometimes this can be caused by just shaving, and then they get a little infection in the follicles. Again, this is usually treated with a topical antibiotic, maybe bleach baths, but it's very common. If you see a pustule, then you know it's a bacterial infection. Okay, let's keep going here. I'm sorry. The weather's getting bad, so. Okay, this is another bacterial infection here. See how red the skin is? It's probably more likely if you put the back of your hand on it, it'd be warm to touch. This looks like a cellulitis. And around the eye is pretty serious. You definitely want to get an antibiotic if someone that has a cellulitis around the face and the sinus cavities. This is an example of another, I'd call this a furbuncle, really bad one. It's probably going to be staph. It has to have usually an incision and drainage, and then antibiotics orally, more than likely. Viral infections. This is an example of herpes zoster or shingles. Remember, that only happens on one side of the body. You can never have shingles on both sides of the body. It's usually unilateral on one side of a dermatome. It is caused by the chickenpox virus. So anyone that's ever had the chickenpox is going to have a risk of having shingles in the future. Very painful because it involves the dermatome and the nerve fibers. You treat this with an antiviral, and unfortunately shingles can last for a long time, especially the pain involved with shingles can last for a long time. Sometimes we give gabapentin for the nerve pain. And if you've never had chickenpox or the chickenpox vaccine, you don't really want to be anyone that has shingles. And if you're pregnant, you want to stay away from the shingles as well. It's a viral infection, and it could involve complicating a pregnancy. This is a chronic herpes infection. It's terrible, isn't it? It's a herpes simplex. It's type 1. Simplex 2 are, going to be the genital herpes. So, type 1 is also found sometimes where you can get cold sores around the mouth. Okay, there's a guy with cold sores. He's kind of got it all over, bless his heart. It's terrible. And the antiviral is going to help that, like acyclovir. Fungal infections, so they can occur on the fingernails. You usually see fungal infections on the nails. That paronychia is chronic, and these are people that hands are always wet and they're always using their hands. But you can get fungal anywhere. I've seen people get it on their body. Tinea corpus. You can get it on the scalp. So tinea is another word for fungal. Yeast is also another word they use kind of hand in hand with fungal. It's related to the dermatophyte infection. So you would use antifungal. In this case, kids can get ringworm on their scalp. It is very contagious. It needs to be treated with usually a shampoo and oral antifungals. This is what I was just talking about. If they get it on their scalp, tinea capitis, they're going to lose their hair, and it is contagious. So this will need to be treated for about 6 weeks with a shampoo and some oral fungal medication. This, I believe, is the body tinea corpus. You can kind of see the little rings there. Ketoconazole shampoo would help with that. Okay, and this is a bad yeast infection of the mouth or thrush. Some medications can cause this. Your cancer patients can have this because they have a low immune system. Intervention for skin infection, you want to properly clean it. If it's bacterial, you can do a bleach bath, which is going to be a half a cup of bleach to a full tub of water. You soak for 20 minutes. You can use the Hibiclens type cleaning. Don't really recommend betadine very much anymore because it burns like fire. And antibacterial soap. You can just use a dial soap. If it's infectious, you want to use isolation precautions. And then you usually want to use oral medications. Sometimes you can get away with just topicals depending on how severe it is. Okay, it goes on to talk about parasite, and really what we see, which is common in our area, is going to be lice. Other things that are going to be common, lice is usually in the hair, it can be in the pubic area. Scabies is very common. If you see scabies, it's usually going to be on the wrist and the armpits and then the abdomen. Itches like crazy. When you're assessing someone's hair, you're going to be looking for these nits. Nits are kind of hard to find. So that's something that it just takes practice to find nits. If you've had kids that have lice, it'd be, a good way for you to experience that. I'm sorry, I'm getting text here. Okay. Parasite, this is scabies. It's not a really good picture of scabies. Wrist is a really common area. Between the fingers, if you have someone who has a rash between the fingers on the wrist and it itches really bad at night, and if their family member has the same thing, it's probably scabies. Very common, but you got to take that that body wash from neck down, leave it on overnight, and then wash it off. Wash the sheets in hot water, all that fun stuff. This is about bed bugs. We don't really have that in this area, but it still talks about the bed bugs. Common inflammation, again, eczema is very common. You can also have a pustular eczema and a nummular eczema, which is just round little dry patches. Eczema is so common, but people hate to hear that diagnosis of eczema because it just means you have dry skin, dry itchy skin. Usually prescribe an antihistamine, sometimes a topical steroid, and then get away from the fragrant materials. This is talking about a contact dermatitis from an earring, contact dermatitis from eye makeup, maybe allergic to whatever this material is here, the contact dermatitis, and this is poison ivy. You can really zone in on poison ivy because it's going to be in a linear fashion, which means it's kind of a straight line, and it usually has little blisters that form. This is more just eczema, atopic dermatitis. Psoriasis, these are going to be scaly patches over the knees and elbows, and you can have a guttate psoriasis, which is what this looks like as well. Those we usually use topical steroids in the beginning, and if it becomes very disfiguring, you can do a systemic medication. You can get this in the scalp as well. So treatment of psoriasis is going to be corticosteroids topically. You can do tar preparation, salicylic acid. You can do ultraviolet light therapy, like low light tanning beds. And then you can do systemic, the Humiras and the Enbrels, things that we use to treat the psoriatic arthritis can also be used. I had one patient, I'll tell you real quick, I'm trying to make this an hour, and he had devastating psoriasis. When he came in, it was on his face, which you don't see very commonly, ears, 95% of his body's covered, and he was depressed and near suicidal. And he didn't have any money, and we got him some help with his medications and got him on Humira. And he was like a completely different person when he came back in 6 weeks. It was amazing. It was the most amazing patient I've probably had to date. So then you have benign tumors. These are keloids. These are scars that have gone bad. This is a seborrheic keratosis. It's an age spot, or as Dr. King called them, barnacles. As you get old, you're going to get them, and they'll never hurt anything. This is a sebaceous cyst. Those are fun to poke a hole in and get some cheesy material out of. Benign tumor, which is again another cyst. You can have fatty tumors. And then this is a skin cancer. This is a squamous cell. It comes with accumulation of sun, a basal cell. It has a little rodent ulcer formation. And then, of course, the worst one is this melanoma here. See how different that looks. Okay, management. If it's a pre-cancer or an actinic keratosis, we will cryosurgery those. It's with that liquid nitrogen. You spray it on there, it freezes, and in a couple of days it falls off. You can also, if it's a basal cell, you'll do this ED&C, and that's where you take a tool and you scoop it out and scrape it, burn it, scoop it out and scrape it, burn it, and you electrodesiccate it. You can excise it if it's a deep squamous cell, or if it's a melanoma. Mohs surgery, if it involves anything on the face, they usually do Mohs. And what Mohs means in a nutshell is when they excise it, they have a pathologist on hand that can look at the tissue, make sure you got it all before you sew it up. Non-surgical is going to be drug therapy and radiation therapy. And it talks about anthrax. Just read about that. Treat it with antibiotics. Never seen that, but I know it's there. I know it's around. Picture what it looks like. Okay, this is Stevens-Johnson syndrome. It's not really common, but it can happen when people take Bactrim, sulfa drugs. To me, it's kind of like a really, really severe drug reaction. Other problems I have here is rosacea, right here. Rosacea is, it's kind of like acne with really bad pustules. You use metronidazole cream to help with that. Lichen planus is just a place this person's rubbed and rubbed and rubbed, and it has thick skin. And you can actually get a lichen planus in the mouth. So just look through here. Here's some other skin disorders. Okay, so what I want you guys to do, I'm going to flip through here so you can look at this case study if you want. This is not your homework. I don't know if y'all have access to this, so I'm going to go through here and allow you to see these questions, and you can come back through them at your leisure. Okay. Okay, so what I want you to do is your assignment. Okay, and I'm going to post it later on Blackboard, so don't be worried, is, again, take a family member you're home tomorrow, the weather's bad, do a skin assessment. I want you to get their demographic, their socio-economic, their allergies, their medicines, family history, past medical history. Okay, so that is your beginning part of your assessment. The second part of your assessment is I want you to do an assessment, okay? Head to toe, look at their skin. Now, you can put the normal stuff down if you want, but what I really want you to focus on is something that's abnormal. It can be something as simple as an age spot, freckling, discoloration, a mole. Hopefully you won't find a pressure ulcer, but it could be that, an itchy patch. Okay? Expand on that. Inspect it, palpate it, describe it, A, B, C, D, E. Okay? I'm going to have an example. I'm going to stick with my melanoma example, so I'll put that on there. Okay, so we've done our assessment. We did our subjective and our objective data. What else is going to be in our objective data? Well, you might throw vital signs in there. I worked in dermatology. I still had a vital sign. Nutritional type thing in there. But then you're going to put your nursing diagnosis, okay? If this person's completely normal, let's just make one up, okay? So just make one up as far as altered tissue perfusion or something in that nature. Let's see if I can find out one. Altered tissue perfusion. Skin tissue integrity, knowledge deficit, things of that nature. Okay, look at one of your books. I don't want to keep y'all as I'm trying to find some others for you. Here we go. Because health promotion is going to be a big thing, right? You're going to educate them. It can be health promotion, knowledge deficit. Okay, so then you're going to do your plan, okay? And your plan's going to be, I'm going to educate this patient on preventing sunburn, okay? And that's your plan, and your intervention is going to be to discuss ways that they can prevent prolonged sun exposure and sunburn, and you're going to list those. That's an example, okay? So that's your assignment. Do it in an ADPI SOAPy format, because I want the assessment, nursing diagnosis, plan, intervention, and your expected outcome. That concept map is a great thing to look at. Your Swearingen's good to look at, and your NCLEX book's good to look at. Listen, this doesn't have to be an assignment that you spend an hour on. But spend a little time on it, and it's going to help you not just on the skin, but it's going to help you put all these processes together. I'll put more explanation up on assignments. Again, it's going to be worth 5 participation points, which basically means if you do a decent job, you're going to get your 5 points. If you have any questions, email me or Miss Kathy. Stay safe, and hopefully I'll be with my group Saturday. Meet in the coffee shop, and if for some reason the weather's bad, we will try to send out a email or text to you guys. My number 870-404-6709. Thank you so much for listening.